like to thank Dr. Sun, too, for kind of teeing this up very nicely. It's kind of like what we do in clinic when we transition a patient. We're not transitioning a talk. CAPRI is the Center for Adults with Pediatric Rheumatic Illness. The island of Capri is in Italy. This is not our clinic. I think it would be really cool if this was our clinic. I'm still I should maybe put in some funding and see if we can get that. But sadly, this is where Capri is probably somewhere over here. We're going to miss this one, I hear. I think the snow's going to pass Boston, but this is Boston. Yeah, I know, right. So I have to give very much kind of an overwhelming amount of credit to Dr. Peter Nigovich, whom some of you may know, who started this CAPRI clinic. He calls it CAPRI. I call it CAPRI because I think it sounds more Mediterranean. But he started this a good 10 years ago, and I was a fellow at the time, and I had an interest in this area. I actually thought about pediatrics myself, ended up in adult medicine, and he's medicine and pediatrics. He does both. And obviously for him, the transition's quite simple. He just changes his white coat and walks across the bridge. But there are obviously not a lot of those special people. So in fact, there are now a number of people who are on staff. Lydia's, I believe, one of our staff members on the CAPRI still. And we get fellows coming through all the time for training. We have a nurse, Fran Griffin, who's our nurse coordinator for CAPRI. Janice McGinnis is a physical therapist, very important for patients with in this clinic. And we have a social worker, which is also very important, as you can surmise from what we've already talked about. This is just a bit of the stuff, though. Anybody, I would speak for my colleagues, any of those folks who work in the Lupus Center at Brigham are comfortable with this concept of picking up the care from our pediatric colleagues for these sorts of patients. So I had Dr. Sun's slide, so I can take that. I had a little bit of help already, so I knew what she was about to talk about. Some of which I will reiterate, and other parts of which I will really emphasize from an adult perspective. What are the goals? Well, first, really, it's the successful transition of pediatric rheumatology patients into adult care. That's one of the things that the clinic was designed to do, the center was designed to do in the first place. There are also patients who might have a primary diagnosis and need to be treated, and they might be 16, 17, 18, kind of an in-between age, where if it's a new chronic illness and maybe a 17-year-old is maybe perhaps better off seeing one of the adult rheumatologists from the beginning, because this transition can be difficult. You see a pediatric rheumatologist for a year or two, and then transition, it can be a bit of an upheaval. So I know that Dr. Sun has certainly reached out to us on patients who are kind of in that in-between, can already tell that they're going to need an adult care soon. We do training of pediatric and adult rheumatologists, future rheumatologists. And there's also this, as has already been alluded to, this mechanism for studying what we do. And that's an important way of getting better. So we're at an academic center, we have that ability. I'm going to focus really mostly on number one, because that's what the talk is for, and that's what people here are probably most interested in. So when does I will call these patients young adults. They might be 14, 15 years old, they might be 22 years old and still rather juvenile. They are young adults, okay? I'll try to focus on that term rather than adolescents or kids. And it's really when the patient and their family are ready, right? I mean, this is something that's already been talked about, but it varies. It's usually around 16 or more that they maybe start thinking about this process. 18, it's a little tough when you get the 25-year-old whose parents walk in for the first time, never try to leave the room, and then you're trying to unravel this tangled mess. So we really like to do this a little bit sooner. Patients, and why do they do this? They do it maybe because, as Dr. Sun alluded to, they may feel too old for the pediatric office, or they might move to a new area from out of town, like where they're attending college, or their parents had to transition or divorce, or whatever it may be that life happens. The pediatric provider may move away. Their pediatric rheumatologist might leave, and the patient's 17 years old, and that might be actually a time to transition. Sometimes you can't have an exhausted relationship with the pediatric provider, and that does happen, unfortunately. You just kind of get to wit's end, and someone's like, boy, what can I do for you? And you're like, well, maybe your time to move on. And in that time, depending on the age of the patient and where they are in life, they may be ready to move to adult care. Sometimes it's just for a second opinion. Not that that's going to be a transition necessarily, but a second opinion, like, well, why don't you, I'd like you to, I told my patients, hey, if you're not satisfied with what's going on, go get a second opinion from someone. It helps me to take care of you if someone else tells you something very similar to what I'm telling you, or if they've got some other different ideas that I haven't thought about. And sometimes that can happen not just from pediatric to pediatric, but adult to pediatric. And so I think that's an important idea. Sometimes it's just geographic access. People who live kind of way outside the city can't get into children's hospital all the time, and it disrupts their life too much. They're taking a day off of school or half a day, and that's too hard for the kid. And then so if you can find someone who's closer, that's adult and comfortable caring for younger adults, then that works well. Sometimes, as has already been alluded to, the patients or their family will just, or actually this patient in particular, would kind of demand or desire some sort of increased independence and be ready for that transition. And then life happens. Pregnancy, incarceration, all kinds of stuff can happen, separation, abuse, homelessness, things that can happen that maybe aren't the best ways to transition, and that's a big disruption in people's lives. But it may also be that sometimes it's compelled to transition for one reason or another. We try to avoid those. So what is ideal for a transition? I would say something that's initiated by the patient, the family, and I should probably say and the pediatric provider kind of together as a unit. I think it'd be really, and we've done this a couple times, where they've been kind of a meet and greet with the adult provider. Like someone's maybe 15, 16, not really ready to transition, but go see Dr. Todd or someone across the bridge for a visit, so at least you know kind of what's on the other side. And then maybe, and you keep coming back to me and keep going back to the pediatrician, and then a few years later, you start, and maybe you pick up that transition process again, just so it's not quite so foreign when you get to that point. This bidirectional communication between the pediatric and adult providers is really important for our patients, and we owe it to our patients to do that. This includes, she set me up so nicely. Thanks, Mary Beth. There's kind of the idea of a patient summary, a letter from the pediatric provider to the adult. Tells me a lot about the patient without having to comb through. I mean, I got a patient this week who had a record this thick. I can go comb through that and try to figure it out. But a summary letter would be such a helpful thing. And eventually, we do want to get through pertinent records, pertinent tests, and that sort of information that we are compelled to review. And then it's also nice to have an interweaving of the pediatric and the adult visits. I tell patients this is not like the claw, right? That machine that picks something up and drops it into a tube, never to be seen again. This is not a patient being picked out of the pediatric world and dropped into the adult world and said, well, we're severing all ties with pediatrics. Your adult doctor is now your doctor. It's not that. It's about trying to interweave those. Maybe there's a year or two of visits that overlap between the pediatric and the adult. That happens a lot, not necessarily in Boston, but I think it happens with some of our patients, but I really get that with my college students who maybe are from California. They come to see me, and then when they go home for Christmas or for the summer, they go see their pediatric doctor. It works really well, and emails work well to just make sure everyone's on the same page. So I found that to be really helpful. That way everybody's kind of comfortable with this process. Let's see here. So what are the barriers? This is something that I spend a good deal of time trying to figure out. What is it that makes it difficult? Well, there is a comfort and a familiarity with the pediatric provider, and that's okay. That's a good thing, right? Patients, families, and even the provider, sometimes they might delay the process just because everybody likes each other and things are going well, and why mess with success? And we totally understand that. But there is that point where someone should say, boy, now it's time to get this going. We don't want to transition you in a time of illness, maybe in a time of health, and that's a good time to do it. And there's always the anxieties of starting over. And I'm sure everybody here has had to get a new doctor of one sort or another. I've got to do that myself. And there's always that, I got to tell my story again, right? Sometimes there's a lack of a soft landing site. So fortunately, we've got our CAPRI clinic at Brigham, but sometimes you have adult providers who are just unfamiliar with transition. So this may be other parts of the country that aren't as blessed with the rich resources that we have. And of course, if there's any kind of a transition that does occur, unfortunately, is when there's poor communication between the pediatric and the adult providers. This concept of being dropped into the new clinic. It's a different institution. There's a different medical record system sometimes, often, and sometimes geographic distance is just part of that barrier. So I went through. So these are my kind of lessons for adult providers. Now this is maybe less for the audience, maybe for a select part of the audience, but this is the lessons to myself, if you will. You have to know who your pediatric doctors are, the pediatricians in the area who are caring for these patients. You know them, they know you, and it really helps everybody feel comfortable that when Dr. Sun says, I'm going to send you to Dr. Burmis, Dr. Feldman, and she's wonderful. She also has a kid who's at Rice University, and that's where you're going to be going, and you guys are going to get along and know each other really well, or something like that. Boy, getting those records, as a provider, if I see a patient who's on my schedule and I know they're going to be in this CAPRI group, I'm like, I got to get those records ahead of time, because if I don't, Children's Hospital and Brigham are not the same medical record. And I even tried to get almost on staff at Children's to get access to the records. It just wouldn't happen. So I can't get access to children's records unless it's initiated by the patient, the family, or the provider. I can't just walk across the bridge and say, give me the records, right? And of course, the more important thing, this is really, I think we forget about this. It also reduces the need for this unnecessary testing. It's not unusual for the first visit, I might not do any blood tests, and the patients love that, right? Because I might have everything I need to know if I've had a chance to go through the records. So who here likes to get blood tests, right? Nobody. I have to commit extra time to these patients. Usually we get 40 minutes for a new patient. I block off at least 60, often at the end of the day, because it's going to run way long. And it's not just that first visit, multiple visits after that it's going to take, so that you get to know them. You can let them tell their story. And it's more than one person telling me the story. It might be the parent, it might be the child, it might be a mixture of everybody. There might be a parent on a cell phone from California who's trying to be involved with the conversation. And there's often a lot of records to review. So you just have to make sure there's extra time. I use that time for the patient, not to review records when they're sitting in my office. I can do that myself ahead of time, preferably. And then it's very important for us as adult providers to communicate back to the pediatric provider so that they know that their patient has landed, all right? I send my notes actually to my patients, which some people find kind of interesting, but I do that so that if my note doesn't get back to the pediatric provider and the patient's going back to Seattle, they've got my record themselves, and so if the provider there didn't get it, then at least the patient has it themselves, and knows exactly what we're thinking about them. And the other thing here is we can't just kind of steal off with the patient, kind of sneak in at the middle of the night, see the patient, never send any record and say, now you're mine. Right? This is not the patient's best interest. Other things, which we have to try to minimize patients being out of school. Try to do it at the end of the day. That tends to work best for, maybe there might be a sporting event or something they missed, but at least they're not out of class time. Boy, we try to minimize gaps in care. That's already come up. And these patients are not always in charge of their own schedule. They may be reliant on others for rides. They may be have responsibilities that we can't even imagine, and they can frequently miss appointments. I'm much more forgiving with these patients than with some of the other ones who are they know better. They got to get to their appointment. They're not doing it. Then these patients, these adolescent young adult patients, we're a little more forgiving. Not everybody transitions well. This is just one lesson, and there can be, and this is there might be resistance if someone comes to me and says, here's the plan, these are my meds, this is what I'm doing, and this is what I'm going to do, and this is my blood test I need, and that's what I need. Can you fill this out for me? Thanks. I'm like, well, their expectations are a little bit different. They've done things one way with one doctor. We're a little different, and it's not right, it's not wrong. It's just, Coke and Pepsi, everything's, they're not the exact same, but there's some similar themes. And then think about, it's important for us as adults to think about the patient not just now, but many, many, many years from now. After I'm retired, these patients are still going to have their lupus, and so I need to be thinking about that from the onset. The pediatricians are good about that with thinking about, not just the adolescent mind, but the idea that this person, we're going to get them into a good place. We're not dealing with an 87-year-old patient who's newly diagnosed with a disease. You're trying to get them through the next few years. These are people who are going to be living with this for quite some time. What about for pediatric providers? I'm sharing these things with you so that I think you should be aware of some of the challenges that we face and sometimes frustrations on both sides of the bridge. So pediatricians, obviously they want to have the same relationship for the same exact reason, to help with that transition process. Expect resistance from their patients, because you know what? It's a compliment. Your patients like you. Their families like you. It's okay if the pediatrician brings it up and the patients are not comfortable with it. Bring it up again. It's okay to do that, and it's something that patients may not be the ones to be initiating this process. Obviously, send the records in advance for all the reasons described. That little letter would be great. And then these transitions take time and effort by everyone. So some providers, you know, an appropriate provider is not going to try to steal off with that patient. But it's also okay, recognize from the pediatrician's perspective, you know, it's okay for that adult provider to reprobe the diagnosis, really make sure they're comfortable with it, make sure that, not just speaking about lupus alone here, but you know, these are the multifaceted, very different types of disorders, and it can change. So it's okay for the pediatrician, for the adult doctor who receives these patients to kind of go in there and kind of question parts of the diagnosis, question why someone's on a certain medicine, maybe tweak things around a little bit. I try not to mess things up too much at the first visit. That's probably not the best time to make big changes, but kind of slowly introduce certain changes, find areas where you can maybe make some adjustments. And then finally, what about for patients and for families who are going through this transition? Okay, this is the third part of the triad. And that is that, first of all, your doctor, by bringing this up, is not trying to kick you out of their clinic. Okay, what do you mean you don't want to be my doctor anymore? That's not the point. Everybody's got to transition at some point. And so pediatricians who do this, and this is not just lupus, this can be, you know, as was already said, it could be sickle cell disease, it could be hemophilia, it could be whatever chronic condition patients may have. That transition has to happen at some point. Starting the conversation early, just opening that conversation doesn't mean you're already catapulted across the bridge into the adult clinic. Some are better than others. It's okay to ask who are the good ones. It's okay to ask questions about anything when you get to the other side and say, well, why are you doing this if my doctor's been doing it this way all along? And so patients sometimes I feel and their families are sometimes afraid to ask questions because they don't want to feel like they're questioning the doctor. I love questions. I'm fine. We've set aside plenty of time for questions. Get those records set in advance. Well, that's the third time you see it. All three folks have to make sure this happens. It's really the patients who have to sign off. And then it does take time and effort again. The doctor's going to maybe question some of the things. You've got to find the right doctor. And these are very similar themes throughout. So it's not like these are all separate points for everybody. These are kind of similar themes for everybody. So I've got some funny slides here. So what's really different? So when a patient comes across the bridge to the Brigham, what are they going to see that's maybe a little different than what they're going to see in Children's Hospital, right? They're going to see old people, okay? That's okay. There's nothing wrong. They're going to see people in wheelchairs. They're going to see stuff. Now, but this can be alarming for, like, you know, the 17-year-old kid who maybe got dropped off by the bus, right? And is supposed to come and find us in this airport, basically. And you know, and they might just turn around and walk out. You know, so they're going to see some folks who might look sick. There might be people on oxygen, on stretchers, and things like that. Ideally, our clinics are not. I mean, fortunately, they're not as nearly as full as wheelchairs as they used to be. What else? Well, so there will be part of the visit. This is more for the parents. There'll be part of the visit where the doctor should see the patient independently. That's because they talk about stuff. And so, you know, the old, I'll so miss you, darling, and those are getting kicked out of the school. All right? And we talk about things that are important that adolescents, young adults have to talk about. I just put it TADS, and that's the old tobacco, alcohol, drugs, and sex. It gets talked about. And pediatricians are good about this also, but it gets talked about across the bridge. It's because these things we've already heard about a lot of this stuff and how it can affect patients' lupus or their life planning. Funny stuff, right? The gown that fits this guy is not going to be the gown that fits this person, okay? And some of our lupus patients in particular, they come in all shapes and sizes, and sometimes we have one size gown, and so this is a, so I try to do as much as I can. I try to do as much as I can before we get to this stage and kind of get through this stage, you know, in as discreet a way as possible so that people don't feel like they're swimming in their gowns, okay? But there is an important, I mean, you do have to examine a patient, but, you know, so some areas that are more particular for patients with lupus. You know, Dr. Sun already mentioned, the younger the onset, the greater the chance for damage over time. I consider ourselves kind of like the forest ranger, right? We're the rheumatologist is forest ranger. You're looking for all these signs of trouble out there, and when there's a problem, you're going to send something out to take care of it. And And the longer it sits there and burns, the more damage that's going to happen. So, be it our medicines or our other interventions, are going to try to put out that fire. It might be a kidney specialist the person has to go see. It might be a dermatologist. It might be myself. But someone's going to have to go out there and put out that fire before it causes too much damage. Well, over time, if that fire is allowed to persist, if someone's not taking their medicines, if there's a delay in seeing a specialist of a different type, there can be damage that you lose that opportunity. Young adults, they've got a lot going on already. So young adults with lupus have a lot going on. There's always the stresses of society, school, starting a career. I hear about so many fights between a girl, one girl and another girl about how one stole a boyfriend and another. I just let them talk. It's kind of entertaining. I've got an 11-year-old and a 9-year-old. So I'm not quite there yet. I'm trying to learn some tips. I'm trying to learn. So I just let them talk. I'm like, what's that app? There's something called like Snapfish or something like whatever it's called. No, Snapchat, right? Snapchat. Yeah, see, I mean, so that's right. So I try to learn all this stuff, but that's terrible. I'm trying to get tips, but I just let them talk. So I'm like, okay, this is going to help me. Your body, bodies change. Steroids change bodies also. I don't want to belabor that point too much, but lupus changes bodies. The physical appearance that can have on the skin or the hair, can really be tough on young adults, on anybody. Obviously, the challenges of keeping track of your medications, we've already heard about that. There can be a lot of them. Kids are worried about this, fertility and family planning. They might be 16, 17 years old, and they've heard, you can't have kids because you've got lupus. You're going to get medicines that are going to make you sterile and never have kids. Or you're going to get, your kids are going to be born with 6 arms because of some of the medicines. And so you have to talk about this kind of stuff. And then this is more for me, and I mean, most patients with lupus are women, and women should try to determine if they feel comfortable with a male provider, because it is an intimate relationship that you have for many, many, many years to come. And there's some that are not, and I'm perfectly fine with that. I might see someone and they never come back. I'm like, wow, where did they go? And I find out they've got a different provider, and I'm not offended by that. I'd much rather feel that someone is comfortable coming to our clinic, and you talk about contraception, you do examinations, you talk about family planning. There's all this kind of stuff. You talk about things that also pertain to young adults. And if someone doesn't have lupus, you still have to talk about that stuff. You can't just throw it on the back burner and never talk about these things. So I'm glad that's already been raised a little bit at this session. But our patients really need to feel comfortable with their provider, gender issues, and everything else in between. So again, just going back to that ideal transition, I think this is my last slide. Oh yeah, that's my last slide. And then this is just the same slide as I put up before. Really, we want to initiate some early conversation, the meet and greet, overlapping, and communication of records. And the patients are vitally important to that. Their families are important to that. We're not trying to steal patients from their families or from their pediatricians. We're trying to make this really a cohesive interweaving of care. So we like to see ourselves like this, right? The charge of the light brigade, kind of coming to the rescue. But sometimes we feel a little bit more like this. It's like we're waiting for the call. Like we're here at your, you give the signal, we'll be involved, we'll be around. Okay, thanks a lot.
Thank you.